So today we are going to discuss a very classical X-ray of pneumothorax. As you can see in this side, in this X-ray, there is a right-sided pneumothorax. You can trace the visceral margin very clearly. So I am going to describe it in a detailed manner. And I will also show the expanded lung after we inserted the chest tube in the pleural cavity. This is the right lung, this is the left lung. This is the cardiac shadow. This is the left side. However, if you watch it very closely, this is a thin line going towards the upside. If I draw it, here it is clearly coming downward, and a thin border of this is exactly what visceral pleura. A thin border of visceral pleura is traceable here, and in this area there are no lung markings. If we compare this area, compare this right lung with the left lung, in this zone the chest, the lung markings are traceable. However, after this visceral pleura is traced, there are no lung markings in this zone. This is the collapsed lung. This all is collapsed lung. I am going to mark it. From here, the visceral pleura is coming. And all this is collapsed lung. This area is jet black. There are no lung markings here. And this is also giving a very important sign. Whenever the costophrenic angle is deepened towards the diaphragm, if we compare this costophrenic angle with this one, here is some pleural effusion. This is the thin visceral line which is going to separate this parenchyma of the lung with this jet black area. This area is extending downwards deeper in the diaphragm. This is known as deep sulcus sign. This is visceral pleura. This all is air, and this is pleural cavity and it is having air in it. This is the visceral pleura, collapsed lung, and this is extending deeper down towards the diaphragm. This is known as deep sulcus sign. On the right side, this is the diaphragm. However, this is blunting of this costophrenic angle. There might be some effusion here, as in this case my patient is a known case of CKD. So the patient may be in overload or having this, there are fluffy infiltrates over the right lung, and patient is on regular dialysis. So this is a bit dirty parenchyma, and patient unfortunately developed this pneumothorax. However, there is no mediastinal shift towards the opposite side, so this is not a tension pneumothorax. Basically, this is a secondary spontaneous pneumothorax. This is the same patient, and this is the chest tube which is inserted in the pleural cavity, and here is a thin margin. And it is going like this. So lung is expanded a bit and the patient's symptoms were relieved. So this is post-op X-ray of pneumothorax in a case of CKD, and the lung is expanding, air leak was positive. this was the chest tube. So this was a classical case of a pneumothorax in a patient of CKD, and this X-ray is pathognomonic whenever there are no lung markings and a thin border of visual pleura is traceable here. We can say that this is a case of pneumothorax. And to differentiate it from a bulla, which is a air containing space in the parenchyma of the lung, the history is very important. If the history is very sudden, which is comprising of sudden chest pain, sudden shortness of breath, then it favors the pneumothorax. And other diagnostic test of pneumothorax in this case is chest CT scan, ultrasound chest for further confirmation.